So hi, my name is Christina Jadushitsky. I'd like to welcome everyone to the physiotherapy approach to prehabilitating and rehabilitating the prostate cancer surgery patient. Today's seminar is going to run approximately 45 minutes. We're going to try and take a break at about the halfway point if needed. Otherwise, we'll just continue on. And then at the end, we're going to learn a highly effective treatment option for the management of incontinence and erectile dysfunction after prostate cancer surgery. All right, so I am a registered pelvic floor physiotherapist, and I work with men, women, and children who suffer from pelvic floor dysfunction. Pelvic floor dysfunction is like an umbrella term that has a myriad of conditions that fall underneath that umbrella term, and it can range from things like painful sex, urgency, frequency, constipation, pelvic organ prolapse, bladder leakage, erectile dysfunction, and so many more. But for the purpose of today's webinar, we are going to be focusing on bladder leakage and erectile dysfunction. So I was fortunate enough throughout my professional career to be presented with several opportunities to work with some of the leading urologists across the Greater Hamilton region. And after spending several days in clinics with them, seeing patient after patient, as well as having the incredible opportunity to go into the OR room and watch these surgeries being done, I was able to take the knowledge that I had acquired from those experiences with the knowledge that I had acquired from my ongoing education after I had graduated from my master's degree, alongside my very passionate commitment to exercise and fitness, which I've been doing for over 21 years now. So when I married all of that knowledge together, I was able to create fairly unique exercise protocols that have been, clinically speaking, helping men recover from the unfortunate consequences of having their prostates removed. So I'm really excited to be able to share that with you guys today, and also share with you that exercise protocol at the end of the seminar today. All right, so without further ado, I like to begin my webinars with sometimes trivia, and in this case, we're going to start with some interesting facts. So did you know that 3.5 million Canadians suffer from urinary incontinence? And of these, 1 in 9 men experience urinary leakage. The most common cause for this is having your prostate removed, and regaining control can take up to 1 year. Furthermore, 60 to 70% of men will have long-term erectile dysfunction following prostate surgery, and the recovery here can take up to 4 years. Now, don't fret. There is hope, and we can reduce these timeframes significantly with pelvic floor physiotherapy. And you're probably wondering, how does physiotherapy help with the management of erectile dysfunction and incontinence? And we're going to talk about that so that you can really understand how it will benefit you. So today's objectives are to discuss what one should expect after prostate surgery. There's a lot of things that men aren't told, and I'm going to tell you all of them. Also, why do these side effects occur? And then, as I mentioned, how does pelvic floor physiotherapy improve the outcomes? And then at the end, we're going to go over that evidence-based exercise protocol that will help with the management of erectile dysfunction and bladder leakage. So what to expect? The first two main common ones are the urinary leakage and erectile dysfunction. And as I mentioned, pelvic floor muscle exercises can help reduce the expected 1 year recovery by as much as 6 to 9 months. So that's pretty phenomenal. And there's more literature coming out now to show that we can actually reduce the erectile dysfunction time frame by a few less months than a couple years. So we're looking at about, just under 24 months. But it's tricky, and we'll talk about why it's tricky to get the erectile function back sooner, because that's more of a neurological disruption, and we're going to touch on that. But let's look here for a second at the various muscles in the pelvic floor, because why are you seeing a pelvic floor physiotherapist for these conditions? And when you think of a physiotherapist, you think, okay, I have, I pulled a muscle, or I have back pain, I have knee pain, or whatever the case is, and you're going there so that they can work on your muscles or joints or ligaments or whatever it is that's been injured. And most people don't realize that pelvic floor is comprised of 3 layers of muscles, and each of these muscles, fortunately for us, we have control over. And so I'm just going to kind of orient you here on what you're seeing in these pictures. So this is the pelvis, And in this bottom picture here, the one that I'm running my cursor over, you are now basically looking at the bottom of this pelvis, okay? So this is a female model. Unfortunately, they don't make male models, which is really unfortunate. But nevertheless, just imagine that this is the muscle that you see here, okay? So this would just be closed, there wouldn't be a hole, and these muscles here are the same muscles that you see in the picture there. So that's just to orient you so that you know what you're looking at when you're looking at the image. And so these muscles here are basically the root of the penis. They extend into the shaft of the penis, and then they create the penis, as does this muscle here. These two here come, and then they create the base of the penis. And most of you guys probably weren't aware of that, but these muscles help to enhance the rigidity of an erection, and they're very active during an erection, okay? Then if we go in one layer deeper, okay, so that would be on the opposite side of this, which would then be on the inside of the pelvis, we're looking at the muscles that maintain continence. And this image here, I don't want you to forget this image. You've got to kind of embed this one in your brains for the rest of the seminar. And certainly if you're suffering from incontinence, you've got to really remember this image right here, because this muscle, the one that wraps around the urethra here, this is the one that you use to prevent leakage. You will become 100% reliant on this tiny little guy right here that wraps around the urethra, and it just closes down on that urethra. Okay, a lot of men tend to overdo their contractions, and overdoing it causes more incontinence, and we'll talk about that in a little bit. Okay, so here we've got the 3 layers, and this is the final layer here. Okay, so this is the innermost layer, and these muscles here are really like a hammock or a sling. They come from the front of the pubic bone here, and then they wrap around all the way to the tailbone in the back. So again, if this kind of helps you a little bit better, you've got the tailbone in the back, and then they wrap around all the way to the front into the pubic bone. And they're there to design to support the internal organs, the bladder, the prostate, and the rectum. And they also, very important, because we're going to discuss this later as well, they also help to stabilize the pelvis. So the pelvic floor muscles have 5 main functions, and as I've listed here, we've got the muscles of sexual function, which we've discussed. So they have responsibility for sexual function. They have responsibility, we call it sphincteric function, which is your continence mechanism. Okay, and then you also have one that goes around the anus to prevent us from passing stools or allowing the passing of stools. And then we've got the supportive function for the internal organs, the stabilizing function, and then the sump pump function, which it's important for these muscles to be able to stretch through their full range of motion, relax completely, and then also contract completely. And unfortunately, a lot of times people hold too much tone in their pelvic floor, and then they can run into other pelvic floor dysfunctions. But the stability, sorry, I'm just going to admit a couple other people that are running late. The stability of the pelvic floor is important, because if you don't have external good stability, then the internal muscles have to do all the work of stabilizing the pelvis. And as a result of that, they may be actually fatigued and not be able to perform their other 4 duties because the outside muscles aren't there to help. And so that's why it's important when you're coming to do physio, it's not just about training these muscles, it's also about training the outside muscles that help provide that stability, because we really want the muscles to be as strong as possible so they can work as well as possible and not be fatigued because we're not, we don't have the proper balance in the muscles inside and out. And we certainly don't want to take from this little guy here that has to make sure that's responsible for our continence. Right. So other things that we can expect after prostate surgery is dry ejaculation. Now, I have a lot of men that come to me and they have an orgasm, which men in and of that self, they are always surprised that they can have an orgasm without an erection. So an erection is not necessary to have an orgasm. And when you do have an orgasm, you will notice that nothing comes out anymore. And that's because the plumbing, essentially, here, if we look, this is the bladder, you've got the prostate here, you've got the seminal vesicles, and then the testicles. And so from the testicles, this is where the sperm comes, okay? And then it travels up the seminal or the vas deferens, and then it arrives at the back of the bladder, and it drops into the prostate, and then all the way out the urethra, until it basically travels out into the vagina. And if that plumbing system is cut, now this is not exactly where it's cut, but it was the best picture that I could find to explain why nothing's going to come out after you've had prostate surgery done. It's because you've essentially removed the plumbing, and now the sperm that's housed in the testicles can no longer make their way out of the penis. Okay, so don't worry about that. That's completely normal. Some men think, uh-oh, is there something blocking? Has the cancer come back? And they start to worry. So don't worry about that. The other thing that you might find is, although you're not going to have ejaculate coming out of the penis, you may find that you have urine that comes out of the penis when you're aroused. And that's actually a condition called climacturia. And that's the involuntary loss of urine during arousal and or orgasm. This can occur in approximately 30% of men. And pelvic floor muscle exercises has shown to decrease the likelihood of this happening, and it certainly reduces it over time as you continue to train these muscles. There are other options, such as emptying the bladder prior to sex, wearing a condom to catch the urine, and using a penile variable tension loop. So that's this image that you see over here. Now, you would just wrap the variable tension loop around the base of the penis. The urethra is housed right in this area here on the underside of the penis. Now, as men, if you've ever tried to pinch the penis where the hole is at the tip of the penis, if you've ever tried to squish the penis, you'll know that it's extremely easy to compress the urethra. So the variable tension loop only applies a very small amount of pressure just so that there's no urine that escapes during those moments. Other things that you can expect, something called Peyronie's disease. It doesn't happen as often, 1 in 6 men after the robotic procedure, and then 1 in 8 men after radiation. Radiation is slightly different. Here, radiation, when tissue is radiated, it's more later on, and that's why it's 3 years after surgery where you'll come to find this Peyronie's disease, because the tissues continue to degrade over time. But typically, we tend to see it appearing at about the 14 months period after a robotic procedure. And it's essentially the deposition of fibrous plaques in the penis. And so here's an image up here where you can see the penis has some fibrotic tissue developing. And as a result, the penis is starting to curve. Now, this can become quite painful. And eventually, it could prevent future penetration. So it is something that you want to try to manage sooner than later. If you do notice that it's developing, please refer or seek help from your healthcare provider. And if you wait until that fibrous plaque is kind of solidified, there are surgical options. But again, you're going in, you're cutting, and then creating more scar tissue. So it kind of creates another negative cycle. So it's not really guaranteed to work. The other thing that is extremely surprising to most men and not often shared is the loss of penile length. So in this image here, you can basically see that the shaft of the penis has basically completely inverted into the base. And that is a result of 2 things. First here, we've got the bladder in this image, and then we've got the prostate gland, and the membranous urethra sits, or the membranous sphincter lives out here. So when you remove this prostate, the prostate in and of itself is about 2 to 3, sometimes 4 centimeters, depending on the size of the man, and prostates can vary from man to man, but roughly about, call it 3 to 5 centimeters. When that gets removed, you've got to reattach the bladder to the membranous urethral portion here. So just removing that bladder and connecting these 2 pieces, you're going to lose anywhere from 2 to 3 centimeters, or potentially more, depending on the size of that prostate. But the other thing that happens is, again, the similar process that happens with Peyronie's disease, but it's fibrosis throughout the entire penis. And that's due to a loss of the nocturnal erections, or nighttime erections, that men have. Men have approximately 6 to 8 nocturnal erections every night, and they're called housekeeping erections, and they happen in an effort to preserve blood flow and a certain amount of pressure into the penis. So let's talk a little bit more about that, because that is also part of physiotherapy treatment to make sure that that doesn't happen. Because when your erectile function does come back, you want to be able to use your penis again, and you don't want to have lost the shaft completely. The issue with scar tissue is that over time, once it settles in, at first it's pliable, but over time it has this propensity to tighten and tighten and tighten and tighten, and it just keeps going in that direction. And then the longer you wait to do anything about it, the harder it is to manipulate that tissue and remodel it. So we got to get on it as soon as possible. And that's why early penile rehab is very important. So the importance of the nocturnal erections, like I had mentioned here, this just depicts that in a flaccid state, there's very low pressure, 35 millimeters of mercury, and that is a signal for the deposition of collagen. So collagen starts to get produced. It's just another fancy name for scar tissue. And so after surgery, men can't have erections immediately because of the nerve damage. And as a result, they're going to have this collagen that starts to get produced. And so that's why that we have to make sure, again, and I'm going to say it over and over, early penile rehab is extremely important so that you do not lose your ability to have an erection when the nerves do regenerate. In an erect state, the pressure is significantly more, almost, well, approximately double, and that shuts down collagen production. Okay, and so the loss of daily nocturnal erections with persistent failure of penile oxygenation leads to venous leakage, as well as the loss of penile length. And then that fibrosis, of course, like we discussed. So here's just an image of your normal erectile function. So here's a flaccid penis. This is the dorsal vein. So a venous leak, you're probably wondering, what's that? Well, if the penis is not engorged with blood, this is a flaccid penis, this is an erect penis, this one is engorged with blood, this one is not, as you can see by the image. If there's no engorgement of blood, then any small, because there's always going to be a little bit of blood flowing through the area, just by the nature of movement, and that's why motion is lotion, okay? But just by the very nature of the blood coming in, it'll just escape, and that's the venous leak, it'll just go right back out, and you will have that low pressure in the penis. When the penis does get engorged and you draw blood into the penis in whatever capacity, and we'll talk about that, you're going to get a compression of that dorsal vein and you won't have that venous leak because the blood won't be able to escape. Okay, so that's kind of why I just wanted to explain what the venous leak was and why it's important to have the penis erect as often as possible. And here is a really fantastic picture to explain why we have why does the penis get affected when the prostate's removed? Well, have a look at all this nerve tissue here, okay? It's coming off the spine and then it's activating or innervating the rectum, the bladder, the prostate, the penis, the testicles. And in the process of prostate surgery, all of these nerves here are cut and they're cauterized, and then there are also traction injuries because they're pulled all the way out the belly button. And for those men who had the robotic procedure done, you'll notice you've got a little scar on top of your belly button. That's because that's where everything comes out. So you can imagine there's quite a bit of disruption to these nerves, and as a result of that, you're going to have what we call this neuropraxic effect, and that's going to result in the loss of those 1,500 nocturnal erections that men get nightly, or yearly, sorry. So like I said again, early penile rehab is important, and so many of you are probably wondering, what is this early penile rehab that she's speaking of? So let's talk about it. Okay, there's 3 lines of treatment. You've got the first line, which is your PDE5 inhibitors, and those are the drugs that we commonly know as Viagra, Cialis, Levitra, and your doctor will prescribe those to you. If he hasn't or she hasn't, then be sure to ask, because they help preserve blood flow to that penis that is no longer allowed or able to do it itself. So we've got to find artificial means to ensure that that blood flow is coming through the penis. The second line treatment option is the vacuum erection device, which is my favorite, and I'm going to talk about that in a little bit, but that's the pump that you see here, okay? And the other second line treatment option is the intracavernous injections. These ones here, you can see the man is pulling on his flaccid penis and injecting an insulin needle at about the 2 o'clock position into the penis, and within about 15 minutes or so, the penis becomes automatically erect. That doesn't happen, I just wanted to reiterate there, that doesn't happen with PDE5 inhibitors. So Viagra and Cialis and Levitra, those drugs will not create a spontaneous erection. You have to have the arousal piece to that. A lot of guys say, oh, that didn't work, I took it and it didn't happen. Well, it's because you need the arousal piece to go with that. So, but the intracavernous injections, those do create the spontaneous erections, and they can last for anywhere from an hour. Some men say 2 hours. But you've got to be mindful not to overdose. So if you find a dosage amount that gives you a satisfactory erection for penetration, I would probably just stick with that, because I have had men who have overdosed and it is not a pretty situation. It's extremely painful. It's called a priapism, and these erections can last greater than 4 hours, and they are medical emergencies. So it's not something that you want to joke around with. You've got to be very mindful of what you're doing with that. Oops. Oh my. Okay. Sorry. Okay, so, and the penile prosthetic implants are the last resort, but they're surgery procedures, so we don't necessarily want to be using those. But they are effective and good satisfaction for men. So let's talk about the pump. And what happens here with the pump, it's fantastic because you can place it on the penis, and this constriction ring here that you see, you place that on the base, you put the flaccid penis through the constriction ring, then you put the pump on, and then you start pumping, or in the case of a vacuorectomy, pump this way, and then it draws in blood by a negative pressure. And through that, you're gonna have an erection. Now, the protocol is to hold this erection for about 3 minutes. So during that 3-minute time, why not work on pelvic floor muscle training, so that you can kill basically 3 birds with 1 stone. You can kill basically the incontinence, you can work on the erectile dysfunction, and you can also preserve penile length, right? So it's my favorite tool because in addition to that, you can actually use it as a weight training tool. And it's important to train the pelvic floor muscles to failure. A lot of men will just go and they'll train a couple rounds, they'll do a couple sets, they'll contract, and then they'll do a few more later on, maybe when they're sitting at the red light or they're sitting at their desk, and then they'll say, oh yeah, I've been doing them. But you're not training to failure, and you have to train these muscles to failure, just like any other muscle in your body, to create hypertrophy, which is muscle growth. And that's what you need of the muscle that you are now 100% reliant on. You can add the vibration device to this to help with orgasms and to rewire your pleasure nerve pathways as well. Okay, so who's at risk? Older patients, if you have a larger prostate size, if you have an elevated BMI, and a shorter urethral length. If you have a larger prostate size, which you see here, the bladder has to work much harder to get out because the urethral diameter is now compressed, so the bladder starts going into what we call overactive bladder, and that's something that we can manage through physio and through some medication. Why does urinary incontinence happen? Well, because the internal sphincter is housed within the prostate, and when the prostate gets removed, you lose your primary worker. You lose the lock that your brain controls, and so you don't even have to think about it. But when you lose the prostate, now you become 100% reliant on the external muscle, and so that's why it takes training so that these muscles eventually become automatic and strong enough to be able to take on the job that they never really had to do. They maybe just got called in on the rare occasion when your bladder was so full and you just couldn't, you didn't have to really hold it. There could be damage to the external urethral sphincter just from attaching the bladder neck to that muscle. Then again, like I said, the increased demand on the striated muscle. So stress incontinence happens when you have an increase in intra-abdominal pressure. So when you laugh, cough, sneeze, those kind of things will cause leakage if your pelvic floor muscle is not strong enough yet. And again, with pelvic floor muscle training, that does help. The urgent incontinence we talked about, the overactive, and then the overflow, if it's usually scar tissue that starts to develop, and scar tissue develops, and then it creates a backup of urine. This is also a medical emergency, so you'll want to go seek help from your doctor. There are other things like removing bladder irritants like caffeine, alcohol, cigarettes, spicy food, milk, those things you want to remove so that you're not faced with a bladder that's contracting too much, trying to expel because it's irritated by these substances. And then also developing new habits. So don't stop drinking water. A lot of men stop drinking water because they think, oh, well, I'm leaking, so if I don't drink, then that'll help. It won't. It's also an irritant, concentrated urine, so don't do that. Avoid emptying the bladder too soon or too often. You want to use, if you're feeling leakage, that's not that your bladder is trying to squeeze, it's just you're not using your muscles to shut down the urethra. So you want to work on urge suppression techniques to prevent the leakage and allow the bladder to fill so that you can get normal function back. Walking is very important because this will allow you to develop the endurance in the muscle. And if you leak a great deal, you can wear a penile clamp at the base of or at the tip of the penis. And some men wonder, why do I leak so much in the afternoon? Well, you've been sleeping all day long or all night. And when you wake up first thing in the morning, your pelvic floor muscles are fresh and they're postural muscles. So the moment you're sitting or standing, that's when they start to work. So naturally, as the day goes on, they're going to get tired. But there is a solution for this, and it is to lie down for an hour a day and rest those pelvic floor muscles so that you have better luck in the later half of the day. You can also visit my website under exercise videos, because I do provide some stretches that should be done, because as I mentioned, the external muscles are just as important as the internal muscles. They all have to work together. And so you'll want to make sure that you stretch the muscles as well as strengthen them. So there's a lot of videos that you can pick up on my website so that you can incorporate that into your routine. With protective padding, I just basically to tell men, get out of them as soon as possible. They're not safety blankets. You want to know when you're leaking. You want to sense it, because you're trying to overcome the leakage. You don't want to let it just absorb in the pad. It's really, as soon as you don't need that pad, if you're not leaking in the morning, don't wear it. If you're not leaking at night, don't wear it. Okay, they're expensive and they also can cause skin infection. So technique matters. Here is an animated version of this ultrasound image that's probably way too complicated for some of you and perhaps not for everyone, but essentially what happens here is back in 1940 we used exercise protocols that were adopted by Dr. Arnold Kegel that were meant for women, and we would tell them to prevent the passing of gas. And what happens there is, if you remove the prostate and now the bladder is being pulled down, then if you tell a man to prevent the passing of gas, wouldn't he not be squeezing on his bladder and therefore causing more leakage? Right, so that's why technique matters, and we can't use the same principles that we used on women. We have to really think about using the front muscles, and that's the striated urethral sphincter and that bulbocavernosal muscle, and they're the ones that are going to help a man maintain continence. Okay, so technique really, really matters, and if you find that you're squeezing your bum, then you're probably doing it wrong as well, because if you're squeezing the outside muscles, they have no responsibility in maintaining continence. As you saw, it is all about the internal muscles. All right, so here's that 12-week high-intensity exercise protocol. And now I am going to be very honest here with everybody, and I hope that you all don't hate me for this. I did not forecast this, because it looks like I'm going a little bit over time, and I have about 2 minutes and 30 seconds left. And I feel like I'm going to get cut off because it's Zoom, and I did not pay for the upgrade. So if I do get cut off, what we're going to have to do is I'm going to send out another Zoom meeting, and hopefully we can all join back. So I'm hoping I don't get cut off, but we'll see how it goes, because I'd really like to spend a good deal of time on this. And what happened was because when I had started the Zoom meeting, we waited quite some time, and that's why the time is almost up. Okay, so the 12-week high-intensity exercise protocol, it involves using both slow twitch and fast twitch pelvic floor muscles. Okay, so the pelvic floor is made up of two different types of muscles, sort of like a marathon runner and a sprinter, if that kind of helps with the analogy. You've got muscles that are there for endurance, and you've got muscles that are there for power, and both of them need to be trained because they have different responsibilities. And you can see here from this, this chart that I've provided here, that in order to do the endurance muscles, you need to contract those muscles for at least 10 seconds when starting out, and then let them go. And then again, contract and hold for 10 seconds and let them go. Okay, and you repeat that 10 times, 10 sets. And then the fast ones are just rapid ones. So you squeeze, release, squeeze, release, squeeze, release at a rate of 1 per second. And I will make all of this presentation available to you. Now, it says I have less than 1 minute, which is really unfortunate, because this is where we were going to sit down and learn how to do this exercise protocol together. I wonder, I think we'll just try and see if it doesn't bump me out, then we'll keep going. If you have a chair nearby, we're going to learn the easiest way to recruit these pelvic floor muscles. So when you sit, you're going to sit on a hard surface. If you're sitting on a couch and you're slouching, that's not going to help you any right now. So what you want to do is you want to make sure that you're sitting on a hard surface, and you want to feel the front of your sit bones. So your sit bones are these two bones on the bottom here. And you don't want to be on the back. You want to be more on the front of those sit bones. So try and find those by rotating your pelvis back and forth. Slouch, and then sit up.